My name is Chris Avery, and I am on the National Climate Assessment Team at the U.S. Global Change Research Program, or USGCRP. Before we get started, I want to draw your attention to the note in the chat box. Audio is disabled for all participants, but if you have questions or comments throughout today's session, please enter them into the chat. If you had technical difficulties, please contact either Tia or Eliza Lustig, who are our technical support group today. Please also note that all participants are expected to be respectful and considerate toward each other per the USGCRP Code of Conduct. Next slide. I will kick off our webinar today with a little bit of background information about the National Climate Assessment before turning it over to our human health and COVID-19 authors. Next slide. The U.S. Global Change Research Program, or USGCRP, was mandated by Congress in the Global Change Research Act of 1990 to, quote, assist the nation and the world to understand, assess, predict, and respond to human-induced and natural processes of global change. The program convenes 15 agencies to advance climate and global change science and to provide useful and usable information to decision makers. Next slide. That same law that established the program also mandates a periodic scientific assessment, which we now know as the National Climate Assessment, or the NCA. The NCA is a quadrennial report that analyzes the effects of global change on several sectors: natural environment, agriculture, energy, land and water resources, transportation, human health, social systems, and biodiversity. USGCRP is charged with assessing current trends as well as projections for the next 25 to 100 years. The NCA is used by organizations and individuals for a variety of purposes, including national policymaking, risk management in the private sector, local mitigation and adaptation planning, as well as by practitioners, utility managers, and educators. Next slide. NCA authors review a very large body of scientific research from diverse information sources. They synthesize that information, examine the confidence in our scientific understanding, and evaluate uncertainties. NCA5 was written by 500 authors and 260 technical contributors from every state in the nation, as well as Puerto Rico, the US Virgin Islands, Guam, and Palau. The NCA is designed to be policy relevant. Authors distill their findings into accessible language framed around the risks to people and important resources. That said, the report is strictly not policy prescriptive and does not advocate for particular viewpoints or policy measures. The NCA uses a range of future projections to help decision makers understand the full extent of possible risks that can be avoided or reduced under different scenarios, and leaves it up to the decision maker to ultimately determine their risk threshold. The assessment is compliant with all applicable federal laws and policies, including the Global Change Research Act, as well as other laws that govern things like information quality, accessibility, and transparency. And finally, the report process involves extensive review, including several opportunities for public engagement, a review by the National Academies of Sciences, Engineering, and Medicine, and several government science reviews. Next slide. So with all of that background, let's take a look at the NCA5 table of contents. Like previous NCAs, NCA5 covers national level topics, regions, and response actions. The report opens with an overview, which is followed by 2 chapters dedicated to the physical science of climate change. And then there are the national topic chapters, the 10 regional chapters, and 2 response chapters, although response actions are also discussed throughout the report. The NCA table of contents has evolved over time, informed by user input. NCA5 added 2 new chapters, one on economics and one on social systems and justice. We also had 5 new focus features on compound extreme events, Western wildfires, COVID-19, which we're going to discuss today, supply chains, and blue carbon. We also have a number of appendices, including a new one dedicated to indicators. So with all of that context about what this report is and where it came from, it's my pleasure to introduce Paul Schramm, the Federal Coordinating Lead Author of the Human Health chapter, who will lead us through the remainder of the webinar today. Over to you, Paul.
Right, thank you, Chris, and thanks everyone for attending. We're happy to have a number of authors and technical contributors to the chapter here to talk about various things contained within it. So I'll start with what's new in the Human Health chapter. As Chris mentioned, this is not the first or the second or the third National Climate Assessment. So what's different? Because there has been a Human Health chapter in each of the previous National Climate Assessments. So when we as authors were reviewing the literature and the state of the science to look for the newest things that were emerging, these are some of the things that we chose to highlight. So for the first time, the Human Health chapter contains information on children's mental health, specifically on women's health and the health of sexual and gender minorities, the health of persons with disabilities. There is a whole focus box on COVID-19, so that's actually in addition to the Human Health chapter. We've included videos for the first time. We'll provide some information on that later in this webinar on tribal elders along the Louisiana coast and how they're adapting to the health impacts of climate change. And this is also the first time that there was a juried selection of artwork throughout the National Climate Assessment. And you can see an example of one of the artworks that appeared in our chapter there on the right. So today, these are the topics that we're going to focus on in this webinar. I'll be presenting on behalf of Mary Hayden, the chapter lead, on the first two key messages in our chapter. We'll be having a section on children's health, on sexual and gender minorities, women's health, spiritual health, the COVID-19 focus box, and then our third key message, which is adaptation and mitigation. So this is much of what's in our chapter, but it's not everything. So I do encourage you to check out the chapter itself and to look through all the figures and all the various things that are available. So starting with the first of our three key messages, this is that climate change is harming human health. We state that it's an established fact that climate change is harming physical, mental, spiritual, and community health and well-being through the increasing frequency and intensity of extreme events, increasing cases of infectious and vector-borne diseases, and declines in food and water quality and security. So you'll notice here we say it is an established fact. So this is something that is new from previous national climate assessments as well, based on a review of a wide body of literature on the current and existing human health impacts of climate change, as well as potential future impacts. The second part of this key message is that climate-related hazards will continue to grow, increasing morbidity and mortality across all regions of the US, and we found that this is very likely that this will occur. So I'll go through a couple of figures that are in this first key message, starting with a focus on heat. Heat is one of the first things some people think of when they think of the health impacts of climate change. And while heat can impact anyone in the US, there are certain people and communities that are disproportionately impacted. So we put together this figure on heat and health equity, and I'll walk through it. There are four things that we highlight as specifically impacting differentials in risk when it comes to heat. Starting on the top left, location. Where you live can determine your level of risk for heat-related illness, especially historically redline communities, including some BIPOC and low-wealth communities, are often hotter than other neighborhoods. This can be for a variety of reasons, for example, because of lower tree cover, or more paved surfaces, asphalts, and buildings that increase the urban heat island. We've also seen that access to cooling centers can be more limited in some areas, or people might not have transportation to go to a cool space during an extreme heat event. So location and where you live definitely impacts your risk during a heat event. On the top right, social and racial factors. We know that some populations just have increased vulnerability to extreme heat. In some cases, they may have less access to healthcare. Also, socially isolated individuals might have less access to cooling centers. And this definitely ties into what I was talking about under the location box as well. In the bottom left, economics. We know that wealth and income can help to determine risk to heat. For example, energy costs and the cost of repairs to limit your ability to afford to run air conditioning, even if you have one. Also, low wealth residents often live in homes that have less protection against extreme heat. For example, they haven't been weatherized. So even if air conditioning is able to be run, it might not be very effective. And then finally, in the bottom right, we have compound risks. Heat doesn't happen in a vacuum. It can happen at the same time or immediately after wildfires or a storm event. One example here is that during the height of the COVID-19 pandemic, we saw that some protocols meant to protect from COVID-19 increase some risk to heat. For example, limits on congregating in shelters, cooling centers. We've also seen that some disadvantaged populations are more at risk for heat-related illnesses during power outages. We've had several examples of where a major storm or a hurricane knocks out power, and it's immediately followed by a heat wave. So compound risks is one other area where we see major impacts from heat. Another example that we had in a figure is changes in climate-sensitive infectious diseases. So this map just shows broadly some cases where we've seen climate-sensitive infectious diseases that have expanded either in where they are, or geographic scope, or when they occur, or seasonality. So in purple, we see diseases that are from vectors like mosquitoes, ticks, bats, livestock, cattle, and other animals. So you can see there are areas where we've seen shifts in West Nile virus and dengue fever from mosquitoes, Lyme disease from ticks. There's a lot of study on how Lyme disease is moving. And then also things like rabies, transmitted by bats and other animals, and vector-borne disease from livestock. Just one example from the green, which is environmental pathogens. You can see vibriosis there. Vibriosis cases are actually projected to increase over 50% by the end of the century under some studies. This is due to a variety of reasons, including warming waters, changing salinity, and sea level rise. You can also see a number of other environmental pathogens that are kind of shifting in the geographic range and seasonality around the country, including valley fever and Naegleria fowleri. So these are just two of the things that we highlighted in how human health is being impacted in the United States by heat and then also by climate-sensitive infectious diseases. Our second key message is on who is impacted, specifically that systemic racism and discrimination exacerbate climate impacts on human health. So we know that climate change unequivocally worsens physical, mental, spiritual, and community health and well-being. That was the focus of that first key message. But there's a lot more evidence now that climate-related impacts disproportionately harm some communities and people who have been marginalized. This can include Black, Indigenous people of color, individuals in community with low wealth, women, people with disabilities or chronic diseases, sexual and gender minorities, and children. And we'll have a number of authors from the chapter go through specific examples of these. I'll start by talking about how climate change creates intergenerational equities. And again, you'll see a figure on this. As younger generations must endure more extreme weather events. We've seen more heat waves, we've seen more wildfires. So this is something that children now will have to face as they age. We've also seen fence line communities, those that are located near hazardous industrial sites, are disproportionately impacted by climate change. For example, those industrial sites can spread pollution through flooding or during heat waves. So they already face higher risks from chemical industrial disasters. And now because of extreme weather events, those are growing. We see this with Superfund sites as well. These are the sites designated by EPA as locations with hazardous materials. That are designated for cleanup, but the hazardous materials are there now. The population around them face increasing dangers as climate change may mobilize the contaminants on those sites. And just to give an idea of who is at risk there, 70% of Superfund sites across the country are located within 1 mile of federally assisted housing. So this gets back to what I was saying about lower wealth communities facing a disproportionate impact. And then we also know climate change can impact food security. About 10.5% of US households are food insecure. And as climate change impacts food security, these households will be disproportionately impacted. So with that, we'll start to go into a few specific examples from this key message. And I'll turn it over to Dr. Bernstein to talk about children's health.
Thanks very much, Paul. I'll cover just a couple of points that stood out in the assessment related to children's health. Next slide. Paul alluded to intergenerational equity concerns, and this figure was in our chapter, but it was also placed as the lead figure in the lead figure for the entire climate assessment. And it really underscores the intergenerational inequity of climate change. What the figure shows is for a child born in North America in 2020, they will be much more likely to experience a suite of extreme events that climate change is influencing over the span of their lifetime as compared to a birth cohort of 1965. The effect is most pronounced for heat, and of course, the effect is greater with more warming. But it's quite apparent for droughts, cyclones as well. And I think one of the issues that this figure makes clear is not just the inequity, which is apparent, but the health effects that would come from these exposures, again, particularly happening early in childhood, where some of these events can create adverse childhood events, which can create toxic stress that creates substantial influence on lifetime health. And so this figure emphasizes the sort of compounding health effects that can occur from increased exposures across a human lifespan to extreme events. Next slide. Paul also alluded to the growing appreciation for the effects of climate change on mental health. This is data from a study that surveyed 1,000 young people ages 16 to 25 in the United States and asked them for their level of worry about climate change. 46% responded they were very extremely worried about climate change. And importantly, 26% of respondents said that their feelings about climate change negatively affected their daily life and functioning, including anything from eating, going to work, spending time in nature, or even relationships. And while there has been, prior to this research, many concerns about individuals who expressed anxiety about climate, there were many anecdotal reports. I think this study really captures, for the first time, the prevalence of these concerns. And it's not just that people are concerned, it's affecting their ability to enjoy life as we would want. So we clearly have a challenge when it comes to children's mental health and climate. I think it's important to note, as we do in the chapter, that the sense of hopelessness and helplessness that may be present is completely understandable. But we also know that messaging, information that's provided to children and young adults around climate tends to weigh towards the harms, but doesn't necessarily speak to the solution space. And so, to me, this figure really speaks to how important it is to make sure that we're communicating effectively, not just what we stand to lose, but the opportunities to move forward, and to make sure at the same time that we are addressing the very real mental health concerns that come from climate change. Thanks. Next slide.
Hello. Thank you so much, Ari and Paul. So my name is Leo Goldsmith. I'm a doctoral student at the Yale School of the Environment, and I'm also the technical contributor on sexual and gender minorities for the Human Health chapter. Next slide, please. So before I go into kind of like the content that was included, I first just want to go over some terminology. So when referring to sex or gender, or sexual and gender minorities and gender equality, both in this section, but also in the women's health section, What we mean is sex is a multidimensional biological construct based on anatomy, physiology, genetics, and hormones. This includes male, female, and intersex. Gender refers to the socially constructed characteristics, norms, roles, and behaviors attributed to women, men, girls, boys, and non-binary people. And because gender is a social construct, ideas about gender vary across societies and time. And then sexual and gender minorities refers more broadly to populations whose sexual orientation and or gender identity and reproductive development is covered outside cultural, societal, or physiological norms. And gender equality refers to the equal rights, responsibilities, and opportunities of all genders. Next slide, please. So I'm very excited to mention that it is the first time in any national climate assessment in which sexual and gender minorities are actually included. And they're included in several of the chapters within the NCA5. However, the human health chapter specifically has a section that talks about some of the impacts of climate change on this population. And so the reason why we chose to use sexual and gender minority versus like some other acronyms out there is because we wanted to be able to encompass all of those different acronyms that people may use for themselves, as well as different ways of like understanding sexual orientation and gender identity. However, for the purpose of this kind of section, I will be using two-spirit, lesbian, gay, bisexual, transgender, queer and questioning, intersex, asexual, plus as the acronym, just so that I can really like emphasize that two-spirit individuals or indigenous individuals who have a sexual orientation or gender identity that's outside of kind of like the norm is specifically highlighted and mentioned. And so the reason why we wanted to include 2S LGBTQI plus communities within this chapter is because this population has higher disparities in terms of health, socially, and also economically. So they're more likely to be unhoused, live in poverty, and also be incarcerated. They also have higher rates of physical chronic illnesses and also mental health um, illnesses as well. And so some of the examples of those are cardiovascular disease, particularly among transgender women, also respiratory illnesses such as asthma and chronic obstructive pulmonary disease, HIV/AIDS, and then also mental illnesses such as anxiety, depression, or PTSD. And so this community has higher rates of these health outcomes before a disaster or a climate-related event happens. And all of those can be worsened by these climate-related events. And so we know that physical and mental health needs are not being met before, but also they're not being met during and after, for example, a climate-related disaster. And so some of the reasons why this is the case is because there are no overarching health protections for 2S LGBTQI plus communities, meaning that it's possible to discriminate against those with different sexual orientations and gender identities in a healthcare setting, particularly for transgender individuals. In some states, it's legal to just flat out refuse to care for those individuals. Also, there's not overarching education on the basis of sexual orientation, gender identity for healthcare personnel. So they may even be unintentionally discriminating against those individuals. And also there is a lack of inclusion in climate and disaster policies, research, guidelines, and infrastructure as well. Next slide, please. And so just to kind of provide some examples of how this plays out, within disasters is that 2S LGBTQI plus individuals have difficulty accessing medications before, during, and after disasters. So this is especially true for transgender individuals, such as obtaining hormone replacement therapy, and also those who have HIV/AIDS. There's also tends to be a stigma, particularly for those who are living with HIV/AIDS. And there was actually recent research that came out about how the wildfires in California, many folks weren't able to actually access their medication or get transportation to access those medications, and that stigma actually prevented them from being able to access proper health care. Also, there was recent data that came out that was analyzed from the Census Bureau's household poll survey that found that 2S LGBTQIA plus individuals have higher rates of displacement, particularly permanent displacement. Also food insecurity and water insecurity 1 month after a disaster hits. And the biggest kind of disasters that seemed to matter the most were wildfires, flooding, and tornadoes. And then discrimination and bias in services and resources, resource distribution before, during, and after disasters also occurs. And so different types of family structures may not be acknowledged, such as chosen family. And chosen family is defined as a group of close ties with individuals who are not biologically related to you, but provide a very important support system. Also, items necessary for 2S LGBTQI plus communities are not included in insurance coverage, which can have economic security implications. And then also destruction of affirming spaces with already limited spaces in which 2S LGBTQI plus individuals may feel safe or find community. You then kind of lose those community ties or places where you can actually access that. And also a place where you can find necessary resources and items needed during this time. And most importantly, these issues are highly intersectional. So 2S LGBTQI plus communities are highly diverse along lines of race, class, ethnicity, age, indigeneity, citizenship, ability, and more. And so we really need to be focusing on those who have intersecting marginalized identities and those who are on the front line. Thank you.
Hi, thank you. My name is Barja Curry. I'm a family physician, and I was a technical contributor for the women's health section of the Human Health chapter. So this was the first time women's health was discussed in its own section because there has been some new data that has addressed this issue. If we can go to the next slide, please. So, you know, climate change can impact women across their lifespan, but the maternal and child health and reproductive health stages have been the most well studied. And so the focus of what we included in this chapter was really based on that. Next slide, please. There were a few specific exposures that there was a lot of more evidence for. And so exposure to excess heat can be harmful throughout pregnancy, but certainly exposure in the third trimester and later in pregnancy appeared to have the largest effect size, as well as it's the extreme heat, so above 18 to 25 degrees Celsius, that appears to have the largest association with poor pregnancy outcomes. Next slide. With regards to air pollution, there are similar impacts that are seen with exposure to pollutants like PM 2.5, and this is often amplified with exposure to excess heat. So air pollution can be harmful at all stages of pregnancy, and it's particularly harmful for pregnant people with underlying respiratory conditions. You can see I've listed some of the actual outcomes that have been measured, both on this slide and the last slide. So preterm birth, low birth weight, and stillbirths are the most well studied, and we see increased emergency room admissions as well as these actual outcomes in the United States and in other parts of the world. With regards to, we can go to the next slide, please. Natural disasters and climate-related disasters. There has been ample evidence in the global health literature and as well as women's health literature that disasters like hurricanes and storms can be harmful maternal and child health, and this can be fueled even more so by climate change. In the short term, disasters can cause immediate physical and psychological stress, and that itself is associated with numerous adverse pregnancy outcomes. Things have been studied like gestational diabetes, preterm birth, cesarean section, low birth weight, and stillbirth again. But also before, during, and after disasters, women, because they can often have caregiver roles and because they often are dealing with existing socioeconomic disparities, women and pregnant people can also have trouble accessing healthcare and disaster relief services, again, before, during, and after these disasters. In the longer term, women can experience persistent mental health effects like PTSD disproportionately. And then in utero exposure to trauma experienced during a disaster can persist as psychiatric illness in children. All of these effects are often amplified in communities of color, especially Black women and girls, as well as low-income communities, and as Leo sort of alluded to in his review, with transgender women. Next slide, please. Other impacts of climate change on women's health are concerns for infectious diseases. So the infectious diseases that and vector-borne illnesses that were reviewed earlier can be particularly harmful in pregnancy, leading to sometimes adverse, again, maternal and child outcomes and congenital issues. In these disaster settings, women, particularly women from low-income communities, can experience malnutrition. And then when these disasters happen, there can be diseases related to water, sanitation, and hygiene issues. I previously mentioned the mental health impacts, but also gender-based violence can occur in these traumatic situations, and there are many long-term health outcomes that can come from that are adverse. Next slide, please. And here too, I think it's important to remember that women and pregnant people, that their risk factors for climate-related health harms can intersect with other risk factors, such as coming from a community of color or coming from a low-income community. With heat, for example, in the US, some of the studies show that the Black and Hispanic women can have almost 2 times the effect size related to dealing with the adverse pregnancy effects of exposure to excess heat. Next slide. So sort of to sum it up, the reason that a lot of the literature sort of points to in terms of why we're seeing gender and sex-based health disparities are, one, related to unique sexual and reproductive health needs, as well as existing social, cultural, and economic differences, and sometimes unequal resource allocation that can intersect to ultimately lead to the disparities that we're seeing. So to that end, I think it's important to understand women are not inherently vulnerable to climate change, but a lot of these additional social economic differences or unequal resource allocation can actually lead to the disparities themselves. So with that, I'll hand it off to the next group.
Well, thanks so much. Hello, everyone. Good afternoon, depending on your time zone. My name is Julie Maldonado, and I'm with the Associate Director of the Livelihoods Knowledge Exchange Network, LICAN, which is a nonprofit think tank. And I'm here today to just provide a brief overview of how climate change impacts spiritual health. Next slide, please. So the increasing frequency and intensity of extreme weather events, wildfires, and slow onset disasters, such as droughts and sea level rise, have not only physical implications, but also real consequences to mental, emotional, and spiritual health. Displacement and forced migration, trauma, and loss of a sense of place and belonging are among the ways that these disasters really harm human well-being. Moreover, these events really further burden our health by disrupting livelihoods, customs, social support systems, and often disproportionately affect overburdened and under-resourced communities. Indigenous communities in particular face unique challenges due to historical injustices such as colonization, forced relocation, and land dispossession, which have disadvantaged them for centuries, continuing through to today. And so as climate change threatens their health, it also further undermines the ability to maintain and access their cultural and economic customs, resulting in vulnerabilities for the entire community. So for Indigenous people and rural communities in particular, there is no separation between the environment and people. Indigenous people are innately connected physically and spiritually to the earth, animals, all living relatives, and sky. And the degradation or destruction of culturally significant places and the loss of flora and fauna relatives disrupt the spiritual connection that these communities have with their land and ecosystem. So shifts in the timing, for example, of ceremonial practices disrupt intergenerational teachings and the sharing of knowledge and wisdom. And that loss of place-based spirituality, traditional livelihoods, and customs reduces resilience and increases the risk to spiritual health. In conclusion, the impacts of climate change really go far beyond physical and environmental factors. That understanding that extreme weather events, wildfires, slow onset disasters, they have a profound impact on spiritual health, with overburdened and under-resourced communities and Indigenous communities bearing the greatest burdens. So it's important that we recognize and address these very distinct spiritual health challenges, ensuring that communities who have been forced into vulnerable circumstances are receiving the resources and support they need to build resilience and maintain their cultural heritage in the face of the climate crisis. Next slide, please. And so through interviews conducted in July 2022, tribal leaders from coastal Louisiana shared their Indigenous and local knowledge, their wisdom, and their experiences of the health impacts and resilience building recovery actions, particularly following Hurricane Ida, but also across time. And Hurricane Ida made landfall in coastal Louisiana in August 2021, and the tribal leaders featured here were among those whose communities took a direct hit from the storm. And so the interviews were recorded during a convening where the tribal leaders came together to share how some of the tribes in Louisiana are really adapting to climate change while upholding sovereignty and working to improve health outcomes. And even just this process here of story capturing and storytelling, demonstrates the kinds of collaborations and the way that it really takes a village to work together on climate resilience. That this was done to acknowledge in collaboration with the First Peoples Conservation Council of Louisiana, the Lowlander Center, the Unitarian Universalist Service Committee, Lichen, the Livelihoods Knowledge Exchange Network, and the Disaster Justice Network. And so the image here is a figure featured in the report, but really it's to point you to the link to access this series of videos. And I'm actually going to put the link into the chat right here, and highly encourage you to take a look and to share with your networks and your community. I'll pass it on to the next person, and thank you, everyone.
Oh, Casey, you're still muted.
I'm on mute, aren't I? Hi, everyone. My name is Casey Ernst, and I'm a professor of epidemiology here at the University of Arizona. And I'm going to share with you some information about a focus box that is in the NCA5, which is related to the intersections between climate change and COVID-19. It was something that in our discussions in the chapter, we just felt like it was such an enormous event that was taking place sort of while we were writing this chapter, that it was important to really think closely and look at some of those intersections. So next slide, please. So today I'm going to really focus on presenting the core figures and tables within this focus box, and then to talk a little bit at the end about some of those lessons learned during the pandemic that might be applied to tackling climate change and health issues, as well as, of course, applying those that knowledge to future pandemics as well. So as you probably are aware, there's a growing evidence that infectious disease systems are influenced by climate and weather through both direct and indirect pathways. When we think about COVID-19, really the early studies haven't identified a strong direct correlation between temperature and weather conditions and COVID transmission. But because it was sort of in that emergence stage, it hasn't really settled yet into more of an endemic state where we might actually start to see more seasonality and more associations with weather variables. But I think that's, is still too premature when we were writing this chapter to be able to identify any clear signals with seasonality. But in general, what we've learned from COVID and from other pandemics is that climate change absolutely has the potential to exacerbate transmission through many different pathways. This is particularly true for zoonotic and vector-borne diseases. As you're aware, zoonotic diseases are those that have an origin in a non-human host, and they comprise most of the emerging pathogens that the world encounters today. The SARS-CoV-2 virus is also originated from a zoonotic origin, but there haven't been any direct links at this stage between its emergence and climate change. And what we do know is relatively tenuous in that nature. In fact, identifying these direct links between climate change and specific disease emergence events is somewhat challenging. There's typically a relatively complex series of events that lead to the emergence of a novel pathogen that span both biological determinants, social determinants, as well as environmental factors. What we do know, however, is that there's substantial evidence that our changing weather patterns, such as altered temperature, rainfall, and humidity, really directly influences disease vectors, non-human hosts, and influences how humans, animals, and vectors interact to lead to events that could more greatly influence chance for spillover. So, for example, the top half of the figure really shows how those factors, such as temperature and humidity, can influence the biophysical processes of disease transmission through changes in this abiotic environment. There's direct influences on lifespan through temperature and time for pathogen replication. And then also precipitation can influence things like habitat formation, Water holding bodies for mosquitoes are really important. And then increasing winter and spring temperatures can lead to extended seasons where vectors, humans, and non-human hosts may interact. You may also have new places where the vectors and non-human hosts can reside. The geographic extent can shift. Habitat changes also alter the way humans interact with disease vectors and non-human hosts. For example, this could be through changing the availability of water for mosquitoes or reduced vegetation in forests for non-human reservoir species. That may actually then drive them into closer proximity to humans and increase the risk of spillover. At the same time, those changing weather patterns also drive different social factors. They can change travel and migration patterns, both of human populations, but also of animal species. And it can drive the patterns of urbanization as livelihoods and food security changes. And those kinds of pressures can sort of work synergistically, where you have food security, insecurity, water insecurity. Those can make populations, both animals and human populations, more susceptible to infectious diseases. Jointly, the shifting patterns in vector, human, and host reservoirs provide more opportunities for disease emergence events, which shift interactions among new hosts and increase susceptibility. Of course, climate change is not just the changes in our average weather patterns, but is also associated with these extreme weather events. The hurricanes, droughts, extreme heat, all of which can lead to things like wildfires. And together, those compounded impacts can have a profound impact on health. The indirect pathways is actually where we identified the strongest relationship between COVID-19 and climate change. As we're aware, it's human-to-human transmission. There's no vector that's implicated in SARS-CoV-2 and COVID that causes COVID-19. So really, it's the strongest link between climate change is really these more sort of indirect compounding events. So during COVID, we all had experiences in food and water shortages. And this was exacerbated in many regions that were also experiencing climate change-driven food and water shortages. So people had this sort of compounding effect. There was also disruptions to supply chains. This could be things like treatments for other infectious diseases, getting sanitary supplies out for people so that they could control spread better, shortages of masks, et cetera. And we also had that profound impact on the economies globally as well as here in the nation, making it a challenge to address multiple threats at one time. The healthcare system also experienced more stress. So you can see that on the very bottom line of the figure. When an extreme weather event occurred, for example, this would force closure sometimes of clinics and hospitals that were already really stressed during the pandemic. They already were running out of beds and had burnout due to the staff, et cetera, having to stretch themselves really thin. And so during other extreme weather events that maybe didn't require evacuation of hospitals, et cetera, but things like extreme heat events, you had cooling centers that were closed due to concerns about transmission that could occur in cooling centers. And there's evidence that individuals, when they were in a hurricane, were less likely to want to evacuate because they didn't want to go to these evacuation centers where it might be more crowded, and they might experience heightened risk of COVID-19 transmission. So all of those factors really work jointly to increase health disparities that were already starkly represented in weather and disasters, as well as in the pandemic. So both these indirect and direct pathways are leading to greater susceptibility, not just to COVID, but to future pandemics as well. All right, next slide, please. So just to go a little bit more in depth into some of the specifics that we identified in our literature review around this topic. So when you look at the relationship between hurricanes and COVID-19, we identified some literature that indicated that during Hurricane Laura, in general, there was COVID-19 transmission that was increased following the hurricanes. There was hypothesized that this was potentially related to the need to evacuate and be in crowded evacuation centers. And in general, displacement due to wildfires and hurricanes was associated with increased crowding and decreased access to sanitation and hygiene that was needed to prevent the spread of COVID-19. Water and sanitation issues were also influenced by drought, particularly on tribal lands where some of the greatest disparities were seen in disease transmission early in the pandemic. And then when you're thinking about sort of these underlying pathological processes, the climate change driven sort of wildfires had a real influence on COVID-19 disease severity. So this decreased air quality was associated with impaired lung function and more severe COVID-19 disease. There's also an impact on these broader well-being indicators, as was discussed previously. The double burden of COVID-19 and climate change hit some populations much harder than others. So as you can imagine, farm workers were considered essential workers during the pandemic. So they were continuing to work, continuing to be in close association with other people, increasing their risk of COVID-19. But then also simultaneously, they were being exposed to extreme heat, droughts, wildfires. And this really influenced the health of farm workers and their livelihoods during the course of the pandemic. So next slide. So just to reiterate a little bit more about this issue with air pollution and exposure to particulate matter, it's pretty clear that particulate matter and exposure to low quality air is not randomly distributed across a population. Many of the same underlying drivers as climate change also affect air pollution, and the impacts are felt much more greatly in Indigenous, Alaskan Native, Pacific Islanders, Black and Latin American populations, more than white Americans. And they also experienced higher hospitalizations and death during COVID-19. Those co-occurring issues really point towards the need for environmental justice-driven solutions that can help reduce disparities, both for pandemics and climate change-driven health impacts. Then finally, the impacts of climate change and pandemics really worked synergistically to impact mental health. As Erin presented previously in the discussion of the human health chapter, climate change is really directly impacting mental health, especially of children who have that growing sense of hopelessness. And during the pandemic, this was really exacerbated. People were losing loved ones. They had a fear of infection. Their routines were completely disrupted. There was a loss of social connection. And so you couple that with the sort of slow burn of climate change, anxiety, and mental health issues. And you really had a crisis for mental health that was felt differentially by those who were low wealth and BIPOC communities that were really facing also this sort of greater loss of friends and family during the pandemic, and those sort of lasting impacts of both that acute sort of mental health crisis during the pandemic, as well as this continued mental health crisis with climate change is sure to be a long-lasting one. So I said we would end with a little bit of sort of lessons learned here. Where do we go from here? I think we learned a lot during the pandemic. There's a lot of overlap in what we need to do to both prepare for the next pandemic, as well as to address climate change and health issues. Some of the specific things that we called out in the chapter include the need to build partnerships and collaborations with communities when there's not a crisis. So trying to develop communication channels, develop trust in science needs to occur when we're not trying to ask people to act urgently or to face some sort of unknown event. This needs to be a continual channel of communication in order to reduce the sort of disinformation and misinformation and mistrust that occurs when something really is urgent and acute. In addition, we really need this collective action among nations. So during the pandemic, I think there were some good examples of shared science. I think there's also some good channels for sharing science for climate change that can be strengthened, particularly in the climate change and health sector as well. I think there's a lot on climate, but really bringing in that health piece is needed, and science diplomacy and sharing can be strengthened from what it was during the pandemic, and that can really start tying together those two worlds. And then engagement with communities and decision makers. We need both bottom up and top down strategies. There are a lot of assets in communities that are undervalued, that can be raised up and shored up to really create resilient structures. When you have a government that is facing an onslaught of multiple threats, it may be difficult to really sort of have top-down programming that addresses all of those community needs. So it's really important to ensure that there's community resilience and investment in that. In addition, any solution that can start to address our already really stark socioeconomic, racial, gender disparities, and those that are facing discrimination or have fewer resources, if we can look at what we have now and start addressing those, that's going to really shore up the resilience for future climate change and health threats as well. We need infrastructure and public health infrastructure, medical infrastructure that can then respond to acute increases in medical burden. So I think when we're all sort of just trickling along, our medical system is relatively good and stable and can serve the needs of a community, but we're not quite as good as being able to flex and increase our capacity when we have acute events. And that's both climate change and pandemic driven. And then really investing, one of the great successes of the pandemic were the mRNA vaccines. That investment of the government in those sort of rapid development of those vaccines really did change the course of the pandemic significantly, and continuing to innovate and create new technologies that can help us address both health threats as well as our resilience in communities to climate change are needed. And being able to really identify early warning signals before the worst impacts are realized, that's important. The pandemic was a pretty fast-moving crisis, but climate change is accelerating. And both climate change and infectious disease impacts grow exponentially. And that really means once you start seeing those early warning signals, acting as soon as you can is important, because it's not a linear growth, it's an exponential growth. And so sort of in conclusion, for all of those sort of targets of improvement, I think it's clear that we are a global partnership across other nations. We're very interconnected. The pandemic demonstrated risk in one area means increased risk for the rest of the world as well. And so really working together on these issues is important to maintain and improve our coordination and our resilience to these increasing challenges that we're facing. Thank you.
Great. Thank you, Casey, for that excellent summary of the COVID-19 focus area. And we're almost to the Q&A. One more thing to present from the health chapter, and that is our third key message, which is, what do we do about it? What is being done about it? So we've heard a lot about the impacts of climate change on human health, what's already happening, what's projected to happen, and who is most impacted. The good news is there's a wide body of literature and a growing body of literature on different things that can be done to address this. So what we found is that timely, effective, and culturally appropriate adaptation and mitigation actions protect health. And there's still a lot of gaps here in figuring out exactly what works and how to implement it in a way that works well. But we do have high confidence that there's a broad selection of adaptation measures that can create climate resilient health systems. And then also, just by working to prevent the release of greenhouse gases or mitigation, we can protect health. So I'll start with adaptation. This is referring to strategies or actions that are designed to protect health. So it's acknowledging climate change is happening. We're having climate-related disasters. What can we do to protect health here? These are just 5 examples that we found literature for that I'll talk about that were in our chapter. One is on reducing air pollution. There are some climate-related increases in air pollution. We found that both reducing that air pollution as well as reducing greenhouse gases, which is often done in tandem, for example, with power plants, can save lives and also decrease the burden on the healthcare system. Another example of an adaptation that can be done at the local or state or territorial level is disease surveillance. So for example, a lot of health departments already have disease surveillance programs. This is really important so that we can track climate-sensitive infectious diseases and non-infectious health outcomes. So we know how they're changing over time. And so that we can also look at when we put in place interventions to protect health, are they working? We need these disease surveillance systems in order to be able to tell that. For extreme heat, there's a wide variety of adaptations that are already been used across the country. Some examples of that include access to cool spaces, whether that be by providing home energy assistance so that people who have their own air conditioning can run it, or by opening public cooling centers. There are also strategies on this around communication, around reducing social isolation, and also on developing municipal heat warning systems, or even reducing heat by improving green infrastructure, by doing things like planting trees or creating more green space to cool neighborhoods. On wildfire, we've seen a variety of adaptations to protect health. These include integrated wildfire management adaptation strategies, which can include things like setting prescribed fires to prevent uncontrolled wildland fires. And emerging researches show that these are critical to reducing exposure to wildland fire smoke, and thus improving health. And then we've also seen kind of community-led resilience and adaptation strategies to just build that local capacity to be able to prepare for and respond to the health impacts of climate change. So really this goes down to what a lot of people have been talking about on this webinar about reducing inequities and strengthening community resilience so that communities are more able to weather these climate impacts. The other side of this, although there's certainly some flow between the two, is mitigation. This is trying to prevent climate change by, for example, reducing greenhouse gases. And what a lot of literature shows is that although these have costs, the economic value of improved health and avoided hospitalizations and deaths from many of these mitigation activities is larger than the cost it takes to implement them. So it is generally an economic positive to implement these strategies. So the first and most straightforward one is just reducing greenhouse gases. By doing this, we prevent climate change, and that helps to improve health by reducing everything that we talked about in key message number 1. With extreme heat, an example is home weatherization. This is often done as a mitigation activity to reduce energy use, which can reduce greenhouse gas emissions, but it also reduces healthcare costs at the same time. So this is something that certainly is both a mitigation and adaptation activity, and we found that weatherization can have a good economic and health benefit. Another example is improving the healthcare sector itself in terms of mitigation and greenhouse gas emissions. In our country, the healthcare sector, so hospitals and everything surrounding that, is responsible for around 8.5% of greenhouse gas emissions. So that's fairly large, and there are efforts underway to transition to more clean energy sources to ensure that just the energy costs of operating our healthcare system aren't adding on to these negative climate impacts. Another thing that we included in our chapter is to be sure that we're avoiding unintended health consequences as much as possible for mitigation strategies. And what I mean by that is sometimes something that's done to reduce greenhouse gas emissions and is well-meaning in that respect can have some negative health impacts that were not meant to be. 2 examples of this are, we talk about air conditioning. Air conditioning and being in an air-conditioned environment is one of the best ways to protect health during an extreme heat event, but it also can exacerbate the urban heat island effect and place additional demands on the electricity grid, which could lead to power outages. And when those air conditioners are powered by coal plants or natural gas plants, they actually result in increased emissions of greenhouse gases and other air pollutants, which then contribute back to climate change. So that's one example of kind of a cycle that could cause harms. Another example is with trees. I talked about urban greening. They're great. They provide shade, they reduce the urban heat island, they protect people during heat waves. They also help with stormwater runoff. But if the certain types of trees are planted, they can actually inadvertently increase pollen levels, which could pose a hazard to those with respiratory health issues such as asthma. So this was something that we noted in our chapter, that these strategies should be done in a way to, as much as possible, avoid unintended health consequences. So those are just some of the adaptation and mitigation actions that we cover in our chapter. And I urge you to take a look at the full chapter to see more about what is already being done across the United States and what can be done to reduce the negative health impacts of climate change. So I want to give, before we move into the Q&A, a huge thank you to all of the authors and technical contributors that participated in this webinar, but also to acknowledge that we were a much larger team. So you can see we had a wide variety of subject matter expertise from just about everywhere, across the country, from universities, from local governments, from federal government. So you can see that full list here. And a huge thank you as well to all of these authors and technical contributors. And with that, I will turn it over to my USGCRP colleagues for the Q&A portion of this webinar.
All right.